presentation and I'm going to tell you about my PhD research. If you bear with me for 2 minutes whilst we set it up, okay? Thank you. Slideshow. Yeah. From beginning. My computer is very slow. Okay. Okay. So, hello, my name's Elizabeth. It's nice to meet you all. Hello. So I'm going to talk to you about my PhD research. So I did my PhD, I finished in 2019. I did it in the beautiful city of Bath. And I did mixed methods research. So I used quantitative methods, qualitative methods, and also I used primary and secondary data to help to address the critical issue of healthcare communication problems that deaf people face. So, to start with, did you know that more than 11 people have some degree of hearing impairment or deafness, and then over 90,000 people are profoundly deaf? So it's predicted that 15.6 million, or 1 in 5 people, will be living with hearing loss in 2035. And that's because people lose hearing with, or like levels of hearing with age as well, don't they?
And also the
oh yeah, living in an urban environment, headphones, loads of things. Yeah, definitely. So let's have a look at. We're recording.
We recording about the Georgia that is recording.
No.
That's for other classes as well.
Oh yeah. Okay. So the deaf community, their first language is actually sign language, and their second language is English. And there's about 100,000 people who use British Sign Language as their preferred language. And it's actually quite important to consider that deaf with a capital D, deaf, is prelingually. So somebody who was born deaf or who was deaf since before they started to learn to talk. That's prelingual with a big D. Deaf with a small letter D is anyone who has a severe hearing problem, but they might have become deaf after they'd already known how to speak. So the deaf community is the one where people are prelingually deaf. And it's important to consider this because deaf people used to communicate in sign language as their first language, and English is complicated for them. It's a second language. They didn't learn it in as much detail as, you know, you and I did. And understanding complicated in English, complicated messages in English can be an issue. So their literacy is at over year 9 student quite often, especially, as I said, with those with the deaf community. And there's also a very strong and linked deaf community that has its own culture and identity. So most people want to use British Sign Language, which is very emotional, has a lot of facial expressions, body language, gestures, and quite often, despite the fact that we live in the same physical space, hearing and deaf people, deaf and hearing people sometimes don't actually engage together. They don't communicate, they don't do things together. And that could be because of language difficulties, but also lack of access. So it's hard for deaf people to engage in healthcare settings or in social settings in a hearing world. So here, as we can see on this slide, there's actually quite poor healthcare communication due to lack of accessible information and BSL that contribute to deaf people having worse health than hearing people. And that's because of low literacy, lack of access, and poor communication. So poor communication could be, for example, so let's imagine a scenario. You are, I am, anyone, a deaf person. They go to the GP. There is an admin lady or man, an administrator at the GP. So they can't hear, right? But the administrator shouting their name, they're shouting their name, they're shouting their name. It's awkward until somebody is like, oh, is that you? And they're like, So they write it down, the administrator. Okay, so that's at the admin, at the getting into the appointment bit. Before that, they have to, get there. And again, the bus driver might say that's £2, love, and they're like, of course they can pay once they figure what that is, but there's lots of steps to overcome. And then when they finally get to GP, maybe the GP ordered a British Sign Language interpreter. Even if the GP did, that sign language interpreter might show up a bit late. And remember, the average GP waiting time, GP appointment time is 9 minutes. So if your BSL interpreter is only a little bit late, you're like, oh, mate. Okay, so imagine in an ideal world, the interpreter's there early, you've met them, you've talked to them, you've explained, you've signed to them what your issue is, fine. Get into the GP office. Okay. So the GP maybe doesn't have deaf awareness training. Maybe they have not got the time to learn, right? So what they're going to do in that 9 minutes, they're going to talk to the interpreter. And sometimes if the interpreter's actually not an official interpreter, but your mom, your mate, they might start making decisions with them, and just because you can't communicate in the same way as they want to, doesn't mean that you don't deserve that. And then there's things like, oh, if a GP's got a beard, deaf people lip read a lot. That's useless. Or if the GP writes things and it's like, so I said, right, a lot of deaf people, especially who became deaf quite young, they have this lower level of written English, especially. So any written English is hard and dull. But imagine like a doctor's scroll. They're like, what is that? And the doctor doesn't explain properly, not in 9 minutes. Deaf people need longer, right? So there's a lot going on there, and all of that can cause deaf people not to attend their doctors, not to know how to, or just, not do what they're supposed to, not understand what the medicines are, their treatments. So that can result in thank you so much, in their health deteriorating, like so. Okay. So some of the barriers we've just discussed, but to reiterate, can a deaf person do an appointment over the phone? No. Like, we spend a lot of time doing appointments over the phone. Yeah. We get appointments over the phone. We get blood tests, medicines adjustments, a lot of quick chats. They can't do that. So what do? They go into a GP. And if they live remotely, that's so annoying. You have to come in every time you want to do a little thing.
Now they put online.
They do, and that helps. So this was done earlier.
After COVID.
But even then, do you think all deaf people, if they can't speak and read as well as we can, do you think using the
If you're
internet?
younger, you can catch, but if you are older, it's harder. I know because my mom is there.
Well, there you go.
Yeah.
That's it. So it can be difficult, but yeah, no, great. When there's apps and there's things online, I think that's great. But on the whole, it's hard. And as I said, there's breakdowns in doctor-patient interactions. And a part of that is not just to do with that it's hard to communicate if you're hearing and somebody's deaf. It's also, if you live in a part of this tight-knit community, if you've always felt that you were protected by the community, then you might not connect to your doctors as well. And if you don't connect to someone, it's hard to kind of make the effort to understand each other. Does that make sense? So it just feels like somebody hearing is controlling your medical life, as it were. And then there's a lack of accessible information. So there's two things there. Number one is if the information is of a high level and there's a lot of it, that's hard because it should be simplified to the language they do know, or there should be sign language videos or something. It shouldn't be like loads of written text to read. That's too hard. And another thing is deaf people don't learn incidentally in the way that we do. So, there's TV adverts, there's posters and things. So obviously, if you don't know English, written English as well, and if you can't hear, you're not going to be able to participate in that part of learning about health as well. Yeah. So, and you can't hear radio things either. Okay, so let's talk about the data. So the secondary data comes from this report called Sick of It by a charity called Sign Health. So 2010, 2013, Sign Health charity and the University of Bristol talked to 533 deaf people. They did a survey. Then there was an assessment for health with 300 people and interviews with 47 people. And what they found out was that health information is often not accessible to deaf people. And actually, there's a lot of money wasted in terms of deaf people not receiving care. For example, up to 30 million per year. So why is that? Because of missed appointments, because of not going to the GP when you should have done early to prevent things. So things escalate. So you end up in A&E a lot of times. So some of the issues mentioned in this Sick of It report was to do with access, communication, lack of health knowledge, health awareness, lack of access of interpreters or bad quality interpreters, and then how deaf people view the hearing world, and then discrimination from the hearing world. And that could be linked with how deaf people view the world. They kind of make that distance as well as hearing people, right? And deaf people generally quite often felt demotivated, unmotivated, and that they weren't responsible, that some big power somebody else was, and that means you're not empowered to look after your health. So my PhD research, what did I want to do based on these secondary findings from the Sick of It report? So I wanted to find out, how can we empower deaf people? How can we make them more motivated? How can we make them feel more responsible and in control for their health? How can we make them engaged with the healthcare process? How can we make it easier for them? And so obviously that should be done through health communication and access, and through dealing with some of the interpreter issues. So we wanted to bring to the deaf people something that they can control themselves, something that they have the control of, right? Improve knowledge and confidence in the healthcare sector. And another thing, we wanted to bring about maybe more acceptance of the hearing world, bring those links, and hopefully, eventually, health outcomes. Okay, so how is that done then? Well, there's this wonderful app. I think me and my friends recently checked it. It is on the App Store. It's called Interpreter Now. So over 500,000 was given to Sign Health, this charity, by the Department of Health in 2014. So basically, Interpreter Now, there it is. It's a app, basically like Skype, but on the other side of it, there's a real life human interpreter. So what does that mean? You don't need to call up interpreters. So if you don't need to call them up, you don't have to pay them for the travel. You can just pay them for the 9-minute appointments. It saves money. Deaf people can control the app. So in my PhD research, we gave them a tablet with maybe 100 tablets to deaf people in different areas. But in general, it means deaf people can decide how and when to communicate about their health. And it's about giving them same accessibility as a phone as well. So the interpreter can translate and kind of deal with that. So that saves time for the deaf people. So lots of positive things. It's a chance to use sign language as opposed to trying to deal with English, which they may or may not know. Yeah. So it's a nice idea. Now, in the study in my PhD, we talked to 100 deaf people who got the app. We talked to 5 different healthcare staff. I think we talked to a doctor, a nurse, and healthcare worker. Then we also talked to project workers, so they were supporting the deaf people in the community. And we took some health markers: blood pressure, weight, height, waist circumference, BMI. And the deaf people were from different regions as well. So there was some from Cumbria, which is rurally and sparsely populated. So that's where the travel bit comes in. That's quite a vast area, but the internet is weak in the Lake District, or I think it's the Lake District. Worcester, a busy city, better internet overall, but lots going on. And then Merseyside, the seaside, also patchy internet in places, but better connected than Cumbria. So we had a difference across the different places as well. So study one of my PhD was about motivation. So we all need motivation to look after our health. And I wanted to check using a survey, did deaf people feel motivated or did they feel frustrated in terms of their basic needs? So need frustration is when your autonomy, your competence, and your relatedness are frustrated. And these basic needs are like, so apart from, if I give you the Maslow's hierarchy of needs, you have at the bottom your physical needs, your hunger, your living conditions need to be safe, things like that. You need water. After that, though, you start having psychological needs like connecting with others, relatedness, like competence of feeling you can achieve goals, and autonomy, feeling like you can make your own decisions, make choices. And that's very important for health, right? Because we have this shared decision-making approach in England, which is basically very much related to that, related to determining and being empowered, right? So we found out that deaf people were indeed very much frustrated. And this was at baseline. So before we did anything, we gave them a survey to see that. So we found out, yep, exactly, they were frustrated, and that results in no motivation or low quality motivation. They felt that they weren't in control. They felt rejected. So self-determination theory, this theory of motivation, kind of suggests that we need to address some of these issues. Ergo, we tested Interpreter Now as an intervention, as a way to improve this motivation as well. So, apart from this theoretical survey that we did about motivation, we also did 3 more things. So study one, remember the PhD is about 3.5 years, so I have time to do all these different things. Study one, we basically did a pre and post. So before you have a tablet with Interpreter Now, do a survey, and after, what is your current healthcare access? Did it change? What is your communication with the doctor? Did it change? So that's called a randomized controlled trial, and we had 2 groups. We had one group who had the tablets and one group who didn't, and this was randomly allocated. But then the group who didn't, after a year, got the tablet, and that's called a waitlist controlled randomized trial. Then we had a qualitative study where we talked with deaf people, with health providers and interpreters and support workers as well. And study 4 was, so the app, every time you used it, it had a little usability questionnaire. How was the call? How long did it take? Little facts about using the app every time. Who do you see? So that's called a feasibility study. Was this a good quality interaction for you? So questions like that. And also we worked out cost effectiveness. So did the app actually save money or not throughout the year? Okay. Any questions before I move on? Okay. So what were the outcomes? Some increases in engagement, some better communication, easier booking, easier. Basically, the main thing that deaf people said they liked is how you can use it as a phone. They like that. They want to be on the same, it puts them on the same level as hearing people, right? And there was cost reduction. So there was about 40,000 that we saved over the year to the community, to the deaf people. So that was cool. So in conclusion, it's important to record deaf people's communication preferences and to give them that. And in fact, there's a deaf charter that was introduced around this time where deaf people can bring the preferences they've written down to any provider, and they have to provide the appropriate thing. So that's important. Then we also said, definitely, like the lady over here said, let's offer online booking. Let's offer longer consultation with interpreters as well, with any online or otherwise, because it just takes a bit more time. And it's important to have deaf training, because the deaf people did say that even with interpreter now, some of the GPs or opticians, they're like, what is this? So interpreter now was pretty effective. And this was supported by both secondary and primary data. Now, this is my last slide. Let me tell you what happens. Let me tell you about real life. This is all pretty and stuff. So what happened? Sign Health, nice charity, put a lot of work into this app. We did it. I'm used to meet with heads of smaller charities that Sign Health was working with on this big project. We used to meet in Birmingham every 3 months, have a discussion, see how the study was going. But the savings or the effectiveness of the study was largely about using it as a phone. In appointments, half the time, especially in Cumbria, it didn't work because this, as you remember at the start, Cumbria has weak internet, 4G. And any Skype, if you ever use Skype with your friends or family, it gets patchy if it's less than 4G. So there's that. And, you know, my PhD showed a level of improvement, but it wasn't enough of a saving. It wasn't like a miracle cure, basically, because nothing is. So what happened? They got a new financial CFO, and he was like, yeah, that's really nice, really good work. Well done, everyone. Good 3 years. Now we're going to sell it to a Scottish charity. And they sold it, but it is on the App Store. And I feel like the fact that such a case happened, it's like a case study or pilot study almost. The fact that it worked to an extent, the fact that when we get better internet everywhere, it could work. It's a good idea. I don't know how it works in Scotland. I've tried to get in touch with them, but I've no idea actually. All right, do you want to stop recording? But yeah, thank you so much. Do we have any questions?
Try to integrate the AI.
This was done in, a PhD started in 2015. It finished in 2018.